permit support for all the patients with severe COVID-19. And but nevertheless, we know that every dying patients equally deserve the service of palliative care. So today we are pleased to have our distinguished speaker, Dr. Richard. He is the consultant in the palliative care and the head of palliative care unit in SARI Hospital, as well as the national advisor for palliative medicine in the Ministry of Health. His main interests includes education in cancer pain management and of life care and effective communications. So without further ado, with all respects, I would like to welcome Dr. Richard to give a talk on today's topic. So Dr. Richard, welcome.
Right, okay, thank you very much, Dr. Tan. Can everyone hear me?
Yes.
Yes, okay. I'm gonna just share my screen now, so just bear with me. Okay, can you all see the screen? Is it coming up?
Yes, Dr. Richard.
Yeah. Okay, great. So yes, thank you very much, Dr. Tan, and a very good afternoon to everybody. And thank you also to the medical department at Queenie for inviting me to speak to you about palliative care in the COVID-19 era. Now, before I actually go on, I'd just like to say that, I actually currently work in a non-COVID hospital. And so personally, I actually have not directly kind of worked with patients who have COVID-19. I have actually managed several cases of PUIs or SARIs who have been in an isolation ward requiring palliative care. But I won't claim actually to be an expert on palliative care in the management of palliative care for COVID-19 patients per se. But as the head of palliative care services in the Ministry of Health, I think that right from the beginning of this COVID pandemic in March, I have actually been, preparing and looking at what would be a suitable response from the Ministry of Health with regards to palliative care in kind of addressing this COVID-19 pandemic in Malaysia. So we have actually prepared some guidelines, and I've actually shared some of that with you in the chat box. So for those of you who would like to just download I've actually put 3 files in the chat box which you can download, and you might find that useful if it helps you. So I'm quite happy for you to share that with you. But this really is the first time that anyone has actually taken an interest in addressing palliative care for COVID-19 patients. And so I really thank you. Thank you very much, Dr. Tan, for your interest and for everyone who is actually here today. I would also like to thank all of you over there in Sabah really for the tireless work that you're putting in for all these patients that we have over there, and all of the people in Sabah as well. And so together, I hope that we can do something which is still very important, meaningful, and continue to promote that caring. Okay, so I'll begin this talk today just by maybe starting off with this introduction again on palliative care. And I'm sure that many of you are familiar with what palliative care is and the WHO's definition, stating that it's an approach that improves quality of life of patients and their families facing the problem associated with life-threatening illness. And so when they actually talk about life-threatening illness, they don't actually specify that it is unique or only for chronic life-threatening illnesses like cancer or like heart failure or chronic lung disease or those kind of typical cases that we would actually be very familiar with requiring palliative care. But it does also include, the scope of it does actually also include acute life-threatening conditions as well. And so that's where in this time of COVID-19, an acute viral pneumonia actually can actually be something that does require palliative care as well. And almost exactly a year ago, we actually launched our National Palliative Care Policy and Strategic Plan for the Ministry of Health. That was on the 16th of November 2019. So it's been actually almost exactly a year. And in that policy, the theme for this policy was to provide compassionate care throughout the healthcare system. And what we hope for is that through this policy and through the development efforts that we will be, embarking on in the next 10 years, we hope that at some point, the entire nation, we would be able to provide access to palliative care for everyone throughout the nation. And we recognize that palliative care is actually a very important component of what is known as universal health coverage. And I think that our ministry actually also is working towards promoting universal health coverage in Malaysia, where we actually understand that this means that all people and communities should have access to the promotive, preventive, curative, rehabilitative, and also the palliative health services that they require. And so what we do hope is that, we can spread it out and reach out. It doesn't matter whether someone's in an urban area or rural area, but we hope that wherever they may be, if they have difficulties and suffering and distress due to their health, we hope that they will be supported. So that's our vision and our vision statements. But in terms of this COVID-19 pandemic, I think that the field of palliative care is not completely unfamiliar with the role that it plays in a viral pandemic, and there has been increasing experience actually with this area, beginning actually in the turn of the century. If those of you who are been around long enough to remember the SARS epidemic, which happened around Asia, and Singapore in particular was quite badly hit. So in 2004, my colleagues from Singapore actually in palliative care actually shared their experience whereby they had to actually initiate palliative care, a role for palliative care in the management of patients during the SARS epidemic. And then later in 2010, actually, if we remember the H1N1 viral influenza pandemic also, which is still something which does occur. And even then in the United States especially, they actually have quite a bit of experience also looking at palliation in a pandemic in such circumstances. So in 2018, about just a couple of years ago, the WHO actually came up with a guideline looking at integrating palliative care and symptom relief into the response to humanitarian emergencies and crises. And of course, as we know, this COVID-19 pandemic is indeed a humanitarian emergency and crisis. And in many countries which are very badly hit, it is actually important to address the symptom relief and palliative care. And I think that a lot of the experience and the wisdom that comes from these comes out of these guidelines actually comes from the experiences that we have had over the years, and also with the experience of the Ebola virus epidemic in West Africa. So in the beginning of this pandemic, around in March this year, several humanitarian health ethics research groups actually came up with a statement talking about alleviating suffering and upholding dignity in the midst of this COVID-19, and what the response should be from nations who are facing this problem, and the role that palliative care plays. And palliative care had been recognized as an integral component of the pandemic response plans and activities during this time. So for us actually in Malaysia and in our ministry, I guess we went from the beginning of this pandemic, we asked ourselves, how should we respond in the face of the COVID-19 pandemic? And I think that our nation has, kind of handled it at a fairly appropriate and kind of successful degree. in the sense that, we haven't had so many deaths, and perhaps our numbers are not as huge as many other countries. And so we have actually, handled, this COVID pandemic in a certain way that has had its fair amount of success. But then again, of course, we do still have a lot of needs. And so if we were to ask, what is the role of palliative care in the management of this COVID-19 pandemic in Malaysia? If you ask me, over the last 7 months or 8 months that we've been dealing with this, I think that what I understand in terms of the role of palliative care in this COVID-19 era is there are 3 main areas that we need to be looking at. The first is, of course, to maintain symptom management and supportive care for patients with incurable life-limiting conditions like cancers and the other chronic non-communicable diseases, just like what we would normally do even before the pandemic. But so that we need to maintain our palliative care services for all these patients, but with an adaptation to the needs of the new norm. So this is actually the role that palliative care plays in the COVID era for our non-COVID-19 patients. And this is in fact the large bulk of, a lot of the role, of course. But then there is another role which we've increasingly recognized. And just today, actually, there was another crisis in my hospital where we need to look at how we can provide symptom management and supportive care for patients with advanced comorbidities, whilst at the same time we're investigating for COVID-19 infection. And so this is where we have patients who we don't know whether they have COVID-19 or not, but they are put in isolation wards. And I'll explain a little bit more about the problem of this in the slides to come. But basically, patients who enter your isolation wards, even though they're being screened for COVID, but they have come to a hospital because they have certain symptoms. And those symptoms also need to be managed and they need to be supported. Now, the third role of palliative care, which is possibly the bulk of what I'm going to talk about today, though, but it's something that we hope we don't have to deal with so much, but the unfortunate reality is that possibly we may have to. If the numbers continue to increase and we also have challenges with our resources, is then to provide symptom management and end-of-life care for patients with severe COVID infections and those with poor prognosis. Okay, so there are these 3 roles, and I'll go through each of this one by one. Right, starting off with our non-COVID-19 patients, as I was mentioning, I think that they do face a lot of challenges. Our patients, the normal patients, who have all these chronic illnesses, many of these patients actually now have been marginalized because of limited access to care, because of MCO and postponement of their treatments. We are trying very hard. There's a backlog of surgical cases that need to be done. And the truth is that this year, in my practice here alone in Leong, we actually have had an increase in patients. We have an increased number of referrals, and we are seeing actually many more patients. And when we look at the stories or their history, we find that actually a lot of these patients were having symptoms just before, which started just before the MCO in March. And then a lot of things got delayed and postponed. And by the time they came to us and by the time we're seeing them now, their disease has actually become very advanced and they are very unwell. So I think a lot of patients have suffered in that way, and we do need to support them. And a lot of patients ongoing are also very fearful of coming to the hospital because they're worried that they will pick up the infection also. So they're fearful of coming to healthcare facilities. So they stay at home and they endure a lot of suffering at home till they finally deteriorate and to a point where they can't stand it and they come to the hospital, and by then so much suffering has already occurred. And then lastly, we also know that a lot of families have been hit quite hard financially, and so a lot of families actually face a lot of challenges to maintain their healthcare, and because there are a lot of these non-medical costs which are included and they can't afford it. And so again, they struggle. So I think just to mention that, in the midst of the chaos of the COVID pandemic, a lot of the other patients who don't have COVID-19, but chronic non-communicable diseases, because of all of the chaos in managing the pandemic, these patients have become more invisible, as they say. It's like sometimes they are not so recognized. And I think that one of the roles that we have tried to play is to maintain that management and maintain that humane kind of clinical care for these patients, and supporting them throughout this difficult time. So we've tried to re-engineer our palliative care services. In Selayang over here, what we're doing is we're utilizing a lot more telehealth and mobile technology to link closer to our patients, so that they don't have to come to the hospital so much. And we've also increased our collaboration with our community palliative care service providers, such as the hospices, because they actually play a really important role. During the last 6 months, they have really been helping a lot to see patients at home, because first, patients are scared to come to the hospital. Second, the hospitals, we are so full of other things, SARIs and stuff like that, that the cancer patients and those with chronic illnesses actually are quickly discharged and sent home, and so they have to get a lot of their care in the community. We've also developed some certain workflows to identify patients who present to us in outpatient walk-in clinics, to make sure that we don't miss PUI cases and SARIs as well. And we also try and utilize the pharmacy network that's out there so that we can ensure continuity of essential medications, and patients don't have to actually keep on coming back to the hospital or traveling far to get their medications, and to make sure that if they're on drugs like morphine, that supply is always continuously provided for them. Okay, then moving on to the second role, as I was saying, this PUI and SARI patients, right, that appear in the isolation wards that we have all around the country. I think that this is actually something that needs to be highlighted, because a lot of patients with chronic life-limiting illnesses actually commonly have dyspnea as their primary symptom. So it may be that they have a lung malignancy, or they have metastatic lung disease, or they may have something like CKD or end-stage renal disease with fluid overload, or they could have metabolic acidosis. They could have decompensated cardiac failure or exacerbations of their COPD or chronic lung disease. And there's a lot of these patients with frailty, the elderly, frail, stroke patients, or dementia. And they come in either with something like aspiration pneumonia, or an orthostatic pneumonia, or community-acquired pneumonia. And so definitely when they come in with dyspnea, it's likely that they will require screening for COVID and be put into an isolation ward. And I think that what we hope is that when patients go into these SARI wards or isolation wards, I know that they're there for a short while, maybe hopefully results come back quickly, but sometimes they could be there for as long as 2 to 3 days. And during that time, sometimes because it is actually difficult, patients, healthcare workers are all in PPE, and so they don't have so much support actually in that time. But I hope that these patients who are in there don't get forgotten, that they may have symptoms that need to be addressed. They have come in because of a symptom, and that symptom needs to be addressed whether or not they have COVID or not. And so these patients actually, even some of them, while they're in the SARI ward, excuse me, over 2 to 3 days, they could actually deteriorate, and they actually may need palliative care during this time. And some of them who come in with severe dyspnea, that actually is a sign that they're entering the terminal phase, and they may require end-of-life care. And so this is where it is actually quite important that doctors who are working in these SARI wards or PUI wards should actually be familiar with basic palliative care management. We hope that at least certain treatments could be continued for these patients, and if they have pain, that the pain can be addressed, and that their breathlessness, whether or not it's due to COVID, if it's very severe, that at least that can be addressed as well. Just to share with you about this PUI SARI case. So just today, actually what's happened in my hospital is that we've just actually taken on a patient who came in with breathlessness, but actually has, because of end-stage renal failure, and actually, of course, was screened because was labeled as a SARI. But at the same time, this patient has a diabetic gangrene in the foot, and actually has and the patient kind of doesn't want to have any surgical intervention done. And so when we were called to see this patient, apparently she's been in the ward for a couple of days already, but she was screaming in pain actually, and she was so distressed because of the pain from her lower limbs. And we just felt that, even though she's in an isolation ward and a SARI ward, yes, we are actually, our role there is to screen and make sure that they don't have COVID, and then we off-tag and send them out. But during that time, we should still be sensitive to their needs and treat, the pain and everything else that we see. So I hope that, that doesn't happen so often. Yeah. So now I move on to talking about the role in COVID-19 positive patients. And this is actually, as I said, more the bulk of what I'm going to talk about today. And again, it's something that, of course, we hope is not something that has to happen too often. But unfortunately, I guess it is a reality that patients who develop severe symptoms and distress, actually, who have COVID-19, I think that they should still be given palliative treatment, even though they're undergoing active COVID-19 management. So these patients, they may not be dying, but if they're having severe symptom distress, they need that distress to be relieved and addressed. And of course, you will have these patients also who are COVID-19 positive, who have pre-existing life-limiting conditions such as cancer or end-stage renal disease, COPD, whatever. And these patients will probably have pre-existing, before this, they already had symptoms of their primary condition. And this still needs to have symptom management to alleviate that distress and that suffering, even while they're undergoing active COVID-19 management. So whether or not they're category 3 or category 4, but they need to actually still have their symptoms addressed. Now, sometimes I think that there is this misconception that many clinicians have, that palliative care is an either-or kind of situation, and it is an alternative to curative and active management. So there is this impression that, oh, if my patient still has active interventions, I'm still doing active management, I didn't label this patient as a gone case, then I shouldn't consider palliative care. And so this is actually a misconception, because the truth is that palliative care should be considered as an adjunct to curative and active management. So it doesn't matter whether you have active management or not for this patient. The fact is that if they have needs, they have distressing symptoms, they should be afforded symptom relief and palliative care. So you can always use palliative care alongside your other active managements. Now, the thing that I guess also I want to touch on is sometimes it is a very difficult topic to sometimes address, because it is actually sensitive, and it's very, it needs to consider a lot of ethical dimensions, right, and principles. But as you know, as mentioned, Dr. Tan introduced the subject today, saying that, we do have to accept the fact that the reality is certain resources may be limited and finite. And if we reach a point where we have too many patients requiring the same resource, we may not be able to give that resource to everybody. And this is where we need to talk about that issue of triaging. So in March this year, actually, the New England Journal of Medicine actually had this short editorial, I think, or report talking about the difficulties of triaging. Robert Trog and his team actually talked about the basis of triaging and allocating ventilators in a pandemic. And so I'm not sure whether many of you are aware of the fact that in Malaysia then, in May this year, we have actually a community of clinicians and some lawyers who are actually very interested in bioethics. And together, they have actually come up with a guidance for clinicians in terms of bioethics and COVID-19. So I've actually put this file, I put this guidance in the chat box. You can download it and have a look at it when you have time. But I'm going to talk a little bit more about some of the contents of the bioethics, this bioethics guidance in terms of triaging, okay? So in terms of triaging, as I said, it is something that is a necessary evil, I guess, but it's something which should be considered as the last resort during a resource crisis. And so I think that in the beginning of this pandemic, in the earlier days in March, April, I did actually ask what's our situation, and when we talked about it in the Ministry of Health, I think it was felt that at this point we, had enough resources. But when we reach a point where you don't have enough resources, then I'm not sure what the situation is over there for all of you in Sabah, but it is something that perhaps needs to be considered if there is a resource crisis. The word triage comes from the French word trier, I think, and which means to separate out. And so triaging is this process of separating out and placing patients at the most appropriate level of care based on their likelihood of benefit, prognosis, their life expectancy due to the disease, and the anticipated quality of life. So please note that actually when you triage someone, it's not based on a single one factor that, oh, this patient's got cancer and so therefore we triage them to this. No, it actually is dependent on several factors, which I will actually go through in the next slide. This triaging is a process which is deemed ethically acceptable in clinical bioethics from both a Western and also an Islamic perspective. And so if you look at that resource, that guidance that I put on the chat group, you can actually see that there is some reference to some of the Islamic fatwas talking about, selection and triaging from an Islamic perspective as well. And triaging actually has a three-step process. The first step is the application of an exclusion criteria. So we would exclude certain patients which are very obviously not going to benefit from this intervention. And then the second step is to then assess what their mortality risk is. So to look at who would possibly benefit the most from this intervention. Now, the third step is after we have applied the intervention, we need to also repeat assessments over time. Okay, so this is actually the proposed triaging, which is in the guidance, the bioethics guidance that I've shared. And so, as I said, step one is the exclusion criteria. So there are several exclusion, and this is actually a common kind of exclusion criteria which most intensive care units actually would apply. First would be if you have someone who's had a cardiac arrest without return of spontaneous circulation despite defibrillation and CPR, brainstem death, patients with hypoxic encephalopathy or persistent vegetative state, those who have no improvement in their respiratory or hemodynamic status or underlying organ dysfunction, those with very disseminated malignancies, so very disseminated malignancies, those with severe sepsis that has not responded to antimicrobial treatment, or those with persistent or developed triple acute organ failures, and children or neonates with underlying life-limiting congenital malformations. And so you would first go through the exclusion criteria, and if this person is not within that exclusion criteria, then you would go on to step two to assess the mortality risk. In my next slide, I'll talk about how that mortality risk actually is another proposal of how we would actually assess that risk. But basically, it looks at three dimensions. First is the short-term survival of the person. So what would their mortality be in the short term? The second would be their long-term survival capacity. What are the prospects that after they get through this, that they will be able to survive with good function and that their outcome will be actually significant? This looks at what comorbidities they may have. And the third is the life cycle scales. So we look at age and potential future years of life to try and gauge, the fairness of selecting someone to have either ventilatory support or something like that. And as I mentioned, the short-term survival scale, sorry, I forgot to mention that one of the things that the scales that they have actually proposed is to use the SOFA scale, or the sequential organ failure assessment tools, and or for pediatrics using the PELOD-2, or this is the pediatric, I think, logistic organ dysfunction scale. So yeah, this would be the second step. Now, after we've actually selected a patient and we've actually put them on an intervention, the third step is to reassess them after 48 to 72 hours, always to look for whether they're deteriorating further, or there's no improvement to the treatment, thereby rendering this intervention quite futile. Or if the patient, after trying this intervention, feels that that's not my best interest and I don't want it anymore, and then they may want to stop. Okay, so this is just to show you, for the short-term mortality kind of prospects, for adults, we would consider using something like the sequential organ failure assessment score, or SOFA score. And this takes into account 6 organ systems: your respiration, your hematological system, the liver function, cardiovascular function, neurological function, and also your renal function. And you can get actually a maximum of up to 4 points on each scale, on each system. And so patients with a higher score obviously have a much poorer outcome and much higher risk of mortality. So this is actually showing you the proposed strategy then for addressing step 2, to look at their short-term kind of their mortality risk. Okay, and so taking into account the SOFA score. So in this proposal, which is actually mentioned in the guidance, and is actually a reference to this particular paper by Bidison in 2019. They look at actually those various dimensions. As I said, the short-term survival, the long-term survival, and the life cycle considerations, and they put it to a point system. So if your SOFA score is very high, points, you get up to 4 points. If your comorbidities, and they list 7 comorbidities here, which includes your NYHA class 4 heart failure, acute advanced lung disease with an FEV1 of less than 25% predicted, your primary pulmonary hypertension with NYHA class 3 or 4 heart failure, liver disease with a Child's Pew score of more than 7, severe trauma, advanced untreatable neuromuscular disease, or metastatic malignant disease, or a high-grade primary brain tumor. So if you have any of these 7 conditions, you will automatically get a score of 3 over in the long-term survival. And then life cycle considerations is based on your age. So those under the age of 50 have are given a lower score. Those at a higher age will give a higher score. So at the end, if you want to use this to determine you've got 3 or 4 patients and you only have 1 ventilator, you can use these dimensions to actually calculate a score, and you'll see the lowest person with the lowest score would be then given the priority for the ventilator. And if you have 2 patients or 3 patients who have equal scores, so they've all got the equal lowest scores, then who do you pick? Then at that point, what is deemed ethically acceptable and logical is to use random lottery draw. So you just either put, you draw lots and see who gets it. So it's your luck, because they have equal priority. But doing something like this and a triaging system like this is meant to be transparent and also fairly evidence-based. Okay, so I think that sometimes when we consider, oh, this patient not for resuscitation, this patient, sometimes the basis of how we decide is a little bit kind of arbitrary. You know, it's a judgment call, clinical judgment. But when we're considering something as serious as triaging, which is very, very sensitive and ethical and emotionally can get very emotionally charged, it is something that we need to actually do with very transparent methods and also evidence-based methods. Okay, so in the guidance by WHO, also looking at that, you know, integrating palliative care with humanitarian in a humanitarian crisis and emergency, they also state that, you know, as we triage someone in the different categories, we also need to recommend certain palliative measures as well. So in someone who is in triage to be in a red group or requiring immediate care, where survival is possible but they need immediate treatment, these patients have very severe disease, severe illness, but they can possibly survive. They need life-sustaining treatment, but at the same time, they also should be afforded palliative care and symptom management. So now, if you're in the yellow group where not much immediate danger of death, but you may have some symptoms, these symptoms also should be addressed, and maybe you may need some palliative care. If you're green, then you're probably quite okay, quite mild. If you do have some symptoms, some simple symptom relief would be sufficient. But I just want to draw your attention to the blue. So this is what we call the expectant group, expected not to survive, and expected where we would not actually escalate care or intervene. And this is where palliative care is a must for this group. And so if we do this triaging in a resource crisis is ethical and permissible. But if we are doing a triaging without providing appropriate palliative care for the expectant group, then this is not so ethical. Okay, so now I'm going to move on to talking about then symptom management for patients with severe COVID-19. And I hope that this might actually help some of you, you know, managing these patients. And but if you have any doubts and questions, I'll be happy to actually answer them. Okay, so but just to kind of give you some idea about what we are dealing with in terms of COVID-19 patients, in July there was a case series that was published from the UK, which was a case series of 101 COVID-19 patients and they who were referred for palliative care. And this study actually kind of outlined the characteristics, the symptoms, the management, and also the outcomes of these patients. And so if you look here, what actually they understood, what came out of that case series, you can see that a lot of their patients, or quite a large proportion of their patients, had these chronic illnesses like dementia, advanced metastatic cancer, chronic pulmonary disease, renal failure, congestive heart failure, stroke, and neurological disorders. And the reasons for referring to the palliative care unit was for, a lot of them were for end-of-life care. And of course, there was some for symptom control. Now, if you look at the outcomes, you can see here that out of the 101 cases, 75 died, but there were 26 patients out of the 101 who actually were discharged and they went back home or went back to their team or went to a hospice. And there were also those who continued under inpatient palliative care. But they did not die and they actually recovered from their COVID-19. So again, this is just to illustrate the point that I made just now, that even though patients have treatment, palliative care still can be helpful, and not all patients who are receiving palliative care will die from their illness, in this case, the COVID-19, but they may need ongoing palliative treatment even after they've recovered. So in terms of their symptoms, what they found were the commonest symptoms included breathlessness, agitation, drowsiness, pain, and delirium. And so these are some of the symptoms that I'll actually be touching on after this. And in terms of the management for these symptoms, you can see that majority of the the medications needed to relieve these symptoms were included things like opioids, morphine in particular, and benzodiazepines, midazolam for the agitation, I presume. And here you can also see that fentanyl was something which was used quite commonly as well. And I presume this is because maybe a proportion of patients also had renal failure. And so I'll talk a little bit about using fentanyl for patients with renal failure after this. If you look at the dosages that they used to treat these patients, actually, you will see that actually the dosage that you need to actually relieve these symptoms is not that high. For morphine, the median was 10 milligrams in 24 hours with a range of between 5 to 30 milligrams. Fentanyl was 100 micrograms over 24 hours, which is about 4 micrograms per hour. And the range was 100 to 200. So it's between 4 to 8 micrograms per hour only. So yeah, if you're looking at transdermal patches, the smallest patch is 12 micrograms per hour. Now, midazolam is 10 milligrams with a range of 5 to 20, and haloperidol 2 milligrams with a range of 1 to 2. So it's not something which requires lots of medication, and it's not too difficult, I would feel. Now, in terms of, so who needs palliative care in the COVID ward, right? I would say that it would be, if you have patients who are already under palliative care teams prior to being admitted for COVID-19, then certainly they would need ongoing care for their, their underlying problem. And those who may not be under palliative care teams, but they may have advanced malignancies or severe chronic medical illnesses requiring symptom management. Those patients, as we had mentioned, who are not for escalation of therapy because they've been triaged to have a poor prognosis, and so they would be expected to be, or they're more of the expectant group. And those who are imminently dying, that we can see that they're obviously dying. Now, sometimes if you're not too certain, does this patient need palliative care or not, you can do something which we often do in palliative care, which is to use this tool called the surprise test. And the surprise test is just a question that you ask yourself. So you ask yourself, would I be surprised if this patient died during this admission? And if your answer to that is, no, I wouldn't be surprised if he died, then maybe this is a patient that you need to kind of consider providing palliative care to. Okay, now before I go on to talking about the management, pharmacological management of symptoms in COVID-19 patients, I'd just like to mention that before we commence these pharmacological measures, consider the following appropriate concurrent measures as well. Now, first, like you may have patients who have underlying medical conditions like COPD or cardiac failure. Ensure that they have optimal medical management for these underlying conditions, like their fluid balance, their bronchodilators, and all of that. Right? Then for those who may have things like anemia, pleural effusion, sepsis, treat the reversible conditions, and hopefully that also gives them some relief. And also don't forget that there are some non-pharmacological interventions that can be used. Now, the common distressing symptoms, which I'll touch on, includes pain, dyspnea, the delirium and restlessness, and also a bit on nausea and vomiting and respiratory secretions. So starting off with pain, now for patients who are already having pre-existing conditions like cancer, and they have cancer-related pain, and they end up in your COVID ward, always check and see if they're already on analgesics. And if they are on certain analgesics, please continue all those medications. Don't stop it just because they've got COVID-19. Unless, of course, they have some complication, particularly acute kidney injuries. So if they are on morphine or they're on an NSAID, of course, you may not want to actually continue with that medication if they've got such problems. But if they're on quite high doses of morphine and they've got an acute kidney injury, I think I'd be happy for people to ask for advice on how to convert this patient to fentanyl, possibly. There's a need to actually convert them to fentanyl. But you could actually just change the regular morphine doses into PRN morphine doses. Okay, but I'll talk a little bit more about that in the next slide. Now, patients who are on regular opioids, you should also remember that they should also be given prescribe PRN opioid analgesia in case they get more pain. And what happens in, I understand in an isolation ward, right? Because patients have to be, you know, our staff are in PPEs, you're all in PPE. So you can't keep on going there. And well, sometimes if they need breakthrough morphine, it takes some time for them to get the morphine and all of that. So what I would recommend is that if patients are on regular opioid analgesia, we should prepare some of the breakthrough medication, like the additional doses of oral morphine, so that they can take it on their own in case they have additional pain, so that they don't have to trouble the staff to come in again to give them their breakthrough medication. That's what we've done for some of our patients here. So we actually put them in isolation, but we give them a few doses, pre-measured doses of the morphine for their breakthrough, and tell them that if you take this, then record it and don't take an extra dose, another dose until 1 hour later, if you need. So because that's what you would do if a patient's at home as well anyway. Now, for those who actually are not on any analgesia, but they're having pain, and you check the pain score, and I would recommend that you use a pain ruler when you assess the pain score, because that's probably the easiest. When you show the pain ruler, you can actually get them to point out, rather than, you know, because when you're in PPE, sometimes it's the verbal communication may not be so clear. So yeah, you can, if you get a pain score of 5 to 6, which is moderate pain, you can just use something like tramadol, 50 milligrams PRN to TDS. It can be oral, IV, or subcut, depending on whether they can take orally. And you can actually add some paracetamol, 1 gram QID for better pain control also. Now, for patients who have more severe pain, if their pain score is 7 to 10, and especially if it's cancer related, but sometimes even if it's not cancer related, very severe acute pain, you can actually give them a stronger analgesia or a stronger opioid like aqueous morphine. And what I've listed here is the starting doses. So the starting dose of aqueous morphine would be roughly around 3 to 5 milligrams, and you can start that 4 hourly and PRN if they have normal renal function. Now, if they have mild to moderately impaired renal function, maybe, but the eGFR is more than 30, you can still use morphine, 2 to 3 milligrams. You can maybe give it 8 hourly initially, and then gradually you can titrate it and increase it to 6 hourly, and then maybe it becomes 4 hourly if you know, the patient still needs more. And we should also give them the option of the PRN doses, as I said. And if we find that in a 24-hour period, a patient takes more than 2 PRN doses per day, it is quite safe to increase their overall dose by 30%, which means that if they take a total of, say, they're taking 5 milligrams 4 hourly, and so in a day, that means they're taking a total of 30 milligrams of morphine. If they take more than 2 PRN doses of 5 milligrams each time, then you can increase their overall dose by about 30%, from 30 milligrams to become 40 milligrams. And 40 milligrams is equal to a dose of about 7 milligrams 4 hourly, or 6.5 milligrams 4 hourly. Now, if patients cannot swallow, so they cannot take oral morphine, you can convert to a subcutaneous route. But just bear in mind that subcutaneous morphine is more potent than oral morphine. And so 1 milligram would be equivalent to about 2 milligrams of aqueous morphine. So if you're giving oral morphine 5 milligrams, maybe you would give subcutaneous morphine of 2.5 milligrams. Okay. Now, for those who have severe renal impairment, which is like an eGFR of less than 30 mils per minute, then you would use a fentanyl infusion, and you can start off your fentanyl infusion with a dose of about 4 micrograms per hour, with aqueous morphine 2 to 3 milligrams as a PRN dose. Okay, so you would dilute, and how do you do this? You can dilute 100 micrograms of fentanyl into 50 cc's and run it at 2 mils per hour, which will give you 4 micrograms, right, per hour. And you can then increase this dose by 1 mil per hour. That means increasing it by 2 micrograms per hour every 6 to 8 hours if the pain still persists. But you need to actually leave it for about 6 to 8 hours to allow the fentanyl to reach steady state. Now you can, as I mentioned, you also need to prescribe the aqueous morphine 2 to 3 milligrams PRN for breakthrough pain, and prescribe concurrent laxatives also to prevent constipation in these patients. Okay, moving on to dyspnea as a symptom. If a patient is able to swallow, now dyspnea, the management of dyspnea, as I said, you should treat the underlying problem like anemia or pleural effusion or whatever it is. But if the patient actually is still very breathless and there's no other reversible kind of factor, then we would treat the patient pharmacologically with an opioid. Opioid therapy is the only pharmacological intervention that can relieve the sensation of breathlessness. And I think this is something which hasn't changed over time. So there's only one pharmacological agent, which is an opioid. And so we would normally choose to use morphine as the first line. So if a patient can swallow, you can use 2 to 3 milligrams. So it's a bit of a lower dose compared to for pain. You would start off with about 2 to 3 milligrams, 8 hourly, and then gradually you can actually increase it to like maybe 6 hourly if they're still quite breathless after 24 hours. And then, so every 24 hours, you can adjust the dose. You could from 8 hourly to 6 hourly, and then gradually titrate to 4 hourly and PRN. This is if you have a normal renal function. Now, if a patient's unable to swallow or is very ill, and I think that sometimes these COVID-19 patients who are very ill and they're very breathless, then maybe swallowing may be challenging. So you can use subcut morphine, again, at half the dose, or 1 to 2 milligrams, 6 to 8 hourly and PRN, and then you gradually titrate similarly up to 4 hourly if they have a normal renal function. Now, if they're still very breathless, you can gradually increase the subcut morphine dose from 1 milligram 4 hourly to 1.5, and then it can go to and then it becomes 2 milligrams 4 hourly, and then you can actually go based on the breakthrough doses, the number of breakthrough doses that they take. Again, if they take more than 2 breakthrough doses, you can actually increase the overall dose by about 30%. Or what we would sometimes do, or what we more often do, is we will total up the total 24-hour consumption of morphine and divide that by 6, and that will give you a new 4-hour dose. Now, you can actually also use it as an infusion, right? And so if you give the patient a morphine infusion, based on the number of PRN doses, you can actually gradually increase the dose. And the maximum that I would recommend is about 15 milligrams over 24 hours. As mentioned in the study, actually, most of the breathlessness could actually be managed with a dose of between 10 to 20 milligrams. Now, for patients with renal impairment, again, we would use subcut fentanyl. And so you also use like 4 micrograms per hour. And you would also but you can also use subcut morphine 1 milligram PRN for additional breathlessness. So you're still waiting to increase your dose, but in between the patient is still very breathless. You can give them a PRN dose of 1 milligram per PRN dose, and you can gradually increase the fentanyl infusion by 2 micrograms every 6 hours till the patient's comfortable, or till a maximum dose of about 12 micrograms per hour. If a patient's still quite breathless also, we may add on a benzodiazepine to help reduce anxiety. And so this would be like midazolam, subcut. You can use it subcutaneously, and probably that's safer than using it IV. 2.5 milligrams as a PRN dose. And you can also use something like sublingual lorazepam. Lorazepam, they just use the tablet, the usual tablet lorazepam, but you can put it under the tongue sublingually, and it will be absorbed faster. So you can use 0.5 to 1 milligram PRN. So this helps to reduce anxiety and helps with reducing the sensation of breathlessness by reducing anxiety. You can sometimes also combine the midazolam with morphine and fentanyl as an infusion cocktail. So sometimes if, say, the patients are about 10 to 15 milligrams of morphine, we can combine that actually about 5 to 10 milligrams of and put that all in the infusion pump and run that over 24 hours. Now, some of the non-pharmacological methods that can also help dyspnea is said to be, because in normal circumstances without COVID, then we would actually tell them to use a fan to cool the face, blow cool air to the side of the face, the lateral side or the cheek. But because in the COVID wards, you don't want to use too much fans and circulate air around. So what you can do is you can dab the face with a wet cotton to cool the side of the face. And that's actually been shown to help to ease some of the sensation of dyspnea as well. Now, moving on to delirium restlessness. So if patients are very delirious, you can use subcutaneous haloperidol, 0.5 to 1 milligram at night, and PRN every 1 to 2 hours. And then the regular night dose can be increased by 1 to 2 milligrams at night, depending on how many PRN doses they need to take. Most patients actually will not require more than 5 milligrams over 24 hours. And this is also in our non-COVID patients. Now, if the patient's very restless, you can use subcutaneous midazolam, 2.5 milligrams PRN. But if they require frequent doses of PRN midazolam, then sometimes it's easier to just put it in a subcut infusion of like between 15 to 20 milligrams over 24 hours. But also allowing a 2.5 milligrams as a PRN dose whenever additional midazolam or relief is required. Now, some of the other symptoms that you may actually encounter, nausea and vomiting, it's quite straightforward. Your first line antiemetic, you can use metoclopramide as usual. But if that's not working, our second line antiemetic would be haloperidol. And we would use like 1 milligram PRN or 1 milligram at night. And we would slowly increase that. But the maximum dose of haloperidol, as you know, haloperidol is an antipsychotic, but it at a low dose, it can be used as an antiemetic because of its anti-dopaminergic activity. But beyond 3 milligrams, there is no further benefit. So you only need to use up to a maximum of 3. Now, a third line antiemetic, you can consider promethazine or Phenergan IV, 25 to 50 milligrams PRN or TDS. Now, the last thing is actually respiratory secretions, which probably could occur, especially with patients. If patients are not actually being ventilated, then they're not going to be able to be suctioned. If they've got lots of respiratory secretions, you can use an anticholinergic like Buscopan or hyoscine butylbromide, 20 milligrams PRN or QID. And you can also use this as an infusion if it's a lot of secretions in the terminal phase, 60 to 240 milligrams over 24 hours. The other thing that you can consider using is glycopyrrolate, but it's more expensive, 200 to 400 micrograms PRN or TDS. And you can also use that as an infusion between 600 to 1,200 micrograms over 24 hours. Okay, so that's about the symptom management. I'm just going to touch a little bit more on communication then. And I guess communication in this COVID era is sometimes challenging because we're wearing PPE, isn't it? And I think this picture here, I think, is quite nice to show how the healthcare workers with PPEs have actually taped, or they've stuck pictures of themselves onto their aprons in the front. And I think that's something which can be quite useful to actually help patients feel a little bit more comforted, and it allows us to actually connect better, to add the human dimension. Sometimes when we're wearing all of this PPE stuff, it's like a spacesuit, and people, sometimes it's hard to even recognize whether you're talking to a man or a woman. So if you can show the person behind all of this, then it helps the patient maybe to feel a little bit more comforted. Although, of course, every day when you finish your round or your shift, you're going to have to get rid of this picture. So you might want to just print a few and put it on. I'm not sure whether you all are doing that now, but I think it is a useful kind of exercise. But in terms of building that connection and rapport while you're wearing full PPE, I think the other important things you need to do is to be able to always try and speak as clearly as possible and look directly at the patient through the face shield, even though all they can see are your eyes, right? But I think that still maintaining that eye contact is important, and you must allow patients to speak. So if you ask them something, give them time to answer back, because sometimes they can't see your mouth, so because you're wearing a mask, and so they don't know when you finish talking, whether you finish talking or whether it's their turn to answer. So you just always pause, give them some time to speak, right? And when they speak, listen attentively to their needs. You can still use body language. You can use certain gestures of body contact despite being gloved and gowned. You can actually like touch their hand or their shoulder or their upper arm if that's appropriate, right? And you can also do things like, put a thumbs up for certain other gestures, which are actually, very warm and comforting to build that connection and rapport. Also try to adjust your position and your posture to approximate the patient's eye level so that you're talking hopefully at the same level as the patient's eyes. Now, when we talk to them, also try to also incorporate the use of certain emphatic phrases to acknowledge patients' family's emotions, like saying things like, I know it must be frightening for you to be here by yourself, or I can see that you are worried about your father's condition, and all of those kind of empathetic kind of statements. Now, these are some possible scenarios which are also in the guidance that I've actually put in. I've put in a guidance which we use in Selayang, and it may help to, there are some questions that sometimes patients and family may ask, and some of the possible responses that you can give. But in all these scenarios, you can see the pattern here is like, for example, you're admitting someone to the isolation ward or the SARI ward, and then the patient says, why does the test take so long? Because they're waiting to be off tag, right? So you start off your response always with an emphatic kind of response, or showing empathy. So you can say, I know it's hard to wait so long, so we're actually empathizing, because to the patient it is a long wait, rather than to say, 48 hours only, what's your problem, I got so many things to do. Don't say that. I know that everyone's tired, but you can just say something empathetic. I know that it's hard to wait. The lab is doing it as fast as possible, but it usually takes about 48 hours. And they say, are you saying no one can visit me, because they're in isolation? And then again, we start off with an empathetic kind of statement, like, I know it's hard not to have visitors, but the risk of spreading the virus is really there. So we certainly can't allow visitors for their safety. And I wish things were different, but in the meantime, perhaps you can actually contact them through the phone and all that. And then when patients say things like, I feel so scared. If someone says that I'm really scared, I think that it is actually a scary scenario for them, and you should respond by acknowledging that, yes, this is a tough situation, and I think anyone would be scared. And then get them to actually ventilate a bit, allow them to ventilate a bit. Would you like to share a little bit more about how you feel with me? So say something like that. Now, the other issue about restriction of visitation, sometimes people are very upset, why can't anyone be with my father or mother? And then, so again, being emphatic, like similarly to why can't anyone visit me? I know this is difficult for you, but the risk of spreading the virus is really there. And so for their safety, we can't allow visitors. But in the meantime, you can use the phone, or you could bring a picture of, someone familiar so that it helps to comfort them. Now, I think that over the pandemic, the use of phone and video family conferencing actually has definitely increased. And I think that it's not actually a bad thing. Breaking bad news, of course, and informing things like deterioration and having those family discussions, ideally, of course, would be best done face-to-face. But if that is not possible, I think that compassionate and communication can still be provided over the phone and by video conferencing. And there has been some data actually and evidence to suggest that, video consultations actually can be an acceptable form of communication for face-to-face, in place of face-to-face interviews. And so in this rapid systematic review that they looked at the evidence out there, global evidence actually supports video consultation as effective, accessible, and acceptable and cost-effective methods of service delivery. And in this recent article actually looking at the use of family meetings. What they found was that 80% of the family respondents actually agreed that they could ask all the questions that they needed, and they felt very comfortable expressing their thoughts and feelings. And they also they felt that they were developing a lot of trust with the clinical team. And 50% of the respondents said that it did help them to understand their loved ones' thoughts and wishes. So it is felt that this can be done, and it is actually an acceptable and efficacious kind of communication medium. And what is also has been recently documented is that communicating via the video actually enhances the therapeutic presence of a healthcare professional compared to a phone call. So actually, video conferencing is in fact superior to a phone call to actually develop trust with and that rapport with the person on the other end. Now, just to talk a little bit about breaking bad news using a phone or video conferencing. Now, it's still the same like breaking bad news face to face. You can still apply these various protocols which are there, such as the SPIKE. Some of you may be familiar with it. The SPIKES protocol stands for the setting, invitation, knowledge, empathy, and summary. So some of the, just a bit of difference, it's not very different, but if you're going to use the phone or the video in terms of the setting, make sure you prepare ahead and make sure you know all the details of this case, because if you're on the phone, you don't want to be flicking back and forth on the, looking through the notes. Make sure you know what's going on first and prepare what you want to actually say to the people on the other end. Now, introduce yourself, explain your role in the patient's care, and get to know who you're talking to and their relationship with the patient. And also, when you're starting out, you should always ensure that, ask them, are you in a safe place and a quiet place? And make sure that they're not driving their car halfway and when you want to break bad news to someone, right? Now, after that, check their perception, right? Just like face-to-face, you would check what the family knows so far and assess the expectations. And then after that, ask for an invitation to actually whether they would like you to explain further. And if you're giving bad news, then provide a warning shot. And after that, once you've given them the warning shot, then provide them the information or the bad news. Do not use any jargon, be very clear and direct. And sometimes you have to be direct, and you do need to say, because if you're on the phone, you may not have the benefit of using facial expressions to communicate what you're trying to say. So you have to be very clear and direct. And if you are, if you're, as I said, if you're using the phone, you may have to be very direct to the point where you might say something like, I'm sorry to have to tell you this, but your father is dying, and using the word dying, Again, after you've given the information, you need to give some time for, allow a silence to let the family process their feelings. You may not be able to see again, if you're on the phone, you don't know what the expression of the patient, the client, the person on the other end is. So they may take time to process things. So give them some time. Don't immediately start talking again, because you give them the news, give it some time. Leave about 30 seconds for them to actually process things. Then after about 30 seconds, perhaps then if there's no mention of anything else, then ask, can I just ask how you're feeling right now? And then use an empathetic or emphatic response to acknowledge those feelings. And then finally, in summary, clarify whatever questions they may have and assess their values and goals. Then you summarize the situation, and then you can actually state what steps will be taken next. And then you can finish off by telling them when they can actually expect another update. And I think that would be a fair kind of way of doing that breaking bad news or talking about deterioration. Now, I'm just finishing off now with this last slide on some phrases that might be helpful when you're communicating with patients with severe COVID-19 and their families and friends. I think some of these phrases may be helpful for you to build rapport also, and also to get very important messages across. So one of those phrases is called the hope-worry statement. So the hope-worry statement is a statement where we try to maintain some hope, so we don't want to be so negative, but we maintain hope but while we still mention that, things are not completely okay, and that there is a possibility of deterioration. So saying things like, we're doing all we can, we hope that your relative will start to respond, but I am worried that there is a possibility he may deteriorate further despite all that we are doing. So this helps to actually give them, it helps them accept a certain information. It gives them some hope, but it helps them to anticipate that something bad might further go wrong. Now, sometimes if we're saying that we think that the prognosis is really poor, we might actually use the phrase sick enough to die, or he's unwell, he's so unwell that he may possibly die from this, So saying things like, he's been actually deteriorating further, or his deterioration has been very sudden, and he is really sick enough to die right now. So that gives a very clear kind of understanding that, what we're dealing with. Sometimes it is actually not, it's not nice to have to say something like that, but I think the truth sometimes is a bit painful, but it will actually be ultimately, honesty still is the best policy. Now, if we want to talk about advanced care planning, when we want to talk about, what should we be doing? What would be the best thing? So using the phrase like, what is important to your loved one at this time? We're hoping for the best, but we should start planning for the worst. What do you think is the most important? So you can say something around those lines, of course. And then, of course, when we finish off, it's very important to always provide that reassurance that we are doing what it is. And most important of all, we will do the best to ensure that, your relative is comfortable. The tone of voice actually can still be used if you're on the phone. So you can actually, try and modulate your tone of voice to show that we are actually caring for your loved one. And then, as I said, using these supportive and emphatic statements like, I'm so sorry, we're talking to you about your loved one by the phone and not face to face. This helps us to build rapport, right? So it's saying that, this must be difficult, such a difficult thing to hear by phone. We are constantly checking on your loved one, and we will ensure that they get what they need. So this is also something that helps you to build rapport and helps them build trust, in what you're doing. And I think this is actually also honest statements of what we are doing, or what all of you are doing for your patients there in the COVID wards. Okay, so this is I feel I should be sharing with you, or I can share with you. And this is just to say that, Dame Cicely Saunders was the founder of the modern we have today. I don't think that she ever imagined that, what she started was actually going to be, looking into these things like viral pandemics and all that. But I think that she did know, and that is really what is important and applicable all the time, is that every individual and every person matters, because you are you as an individual, and you matter until the last moment of your life. So no matter how unwell the person is, however poor the prognosis is, we still need to do the best that we can to care for that person and show that care. And I know that sometimes in managing this pandemic, right, and patients who have poor prognosis, and especially if we are in the situation where we need to triage, and it makes us very morally distressed. Actually, we feel this moral distress that, we should be doing more, and we are marginalizing patients. But we know that this is something that, can't be avoided. But if we keep on, providing that care and that comfort, that I think that is actually the most important thing. And I think for healthcare professionals, the experiences that we've actually heard from our colleagues in Italy and in Spain and in the UK, actually, I think that they all feel that at least providing that palliative treatment actually gives them some sense of completion and comfort, actually, and it kind of helps to energize them to feel that what we are doing still matters, and what we are doing is still meaningful as healthcare professionals. So with that, I thank you for your attention, and I'm happy to answer any questions if there are any. Thank you.